I'm going to be discussing the diagnosis of a factitious disorder imposed on the child. In this case, a factitious attachment pathology, sometimes a factitious phobia. So to begin with, I want to emphasize to everybody that the pathology we're dealing with is a pathology of lies, that it's a false pathology. And the types of pathology that were involved within the family courts is first we have a persecutory, first we have the personality disorder pathology of the parent. That's narcissistic, borderline, dark personality parent. They are highly manipulative, and this has to do with unresolved trauma. And I'll discuss the personality pathology in a separate seminar. Then we have the delusional thought disorder, the persecutory type, from the collapse of the narcissistic, borderline, dark personality parent under stress, under the stress surrounding the divorce, and that is the product of unresolved trauma with them. In addition, we have two variants of a factitious disorder. The first is a false attachment pathology being created in the child for secondary gain or reward to the parent. And then sometimes, not always, but sometimes, we will get a false anxiety disorder, a specific phobia, mother phobia or father phobia, that is created in the child, again, for secondary gain to the pathological parent. Now, regarding the personality disorder features of the pathological parent, they provide sort of the context for all the other displays of pathology. So the personality pathology is the product of unresolved attachment trauma and attachment pathology in the childhood of the parent. And there's two variants. One is the narcissistic variant. It would be disorganized attachment with anxious avoidant overtones. And here we're looking at the dark triad and the dark tetrad. So I'll discuss this more fully when I discuss personality pathology. But we're primarily worried about the dark personalities, dark triad, vulnerable dark triad, and dark tetrad. And they are the variants of the narcissistic and borderline pathology. Then with the borderline, we have disorganized attachment with anxious ambivalent overtones. That's your vulnerable dark triad variant. And the dark personalities, something to understand about them, is that they are subclinical, meaning that they are not diagnoses. They are constellations of a group of personality characteristics that involve narcissistic, psychopathic, borderline, extremely manipulative, and sadistic. And so the dark personalities are a particularly malevolent human being. And that's what we have in the family courts. So regarding the personality pathology and its role in the overall set of symptoms and pathology in the child, it involves a transgenerational transmission of trauma from the childhood of the narcissistic, borderline, dark personality parent to the current family relationships. And the personality pathology is created in the attachment pathology of their childhood and then goes on to create the current attachment pathology. And so the current pathology is being mediated by the personality pathology of the narcissistic, borderline, dark personality parent. Now, regarding diagnosis, the parental personality pathology of the allied parent is not being diagnosed specifically. That's not where our focus is. The treatment plan is going to be focused on the child and the targeted parent bond, and not on the allied parent's personality pathology. And so the personality pathology of the allied parent provides the context, and it's a context feature of the pathology. It's what's referred to as a mediating variable in the creation or the transmission of the pathology. A factitious disorder and its relationship with personality pathology is that there's two types of factitious disorders. One is where the person is creating a false display of pathology within themselves, and the second is when they're creating a false pathology in someone else. So a factitious disorder is for secondary gain or some sort of reward to the person for producing the false pathology, for presenting as being ill or injured. And for the individual factitious disorder, when the person is doing it to themselves and presenting that way, that's typically associated with a narcissistic psychopathic personality, the dark triad or the dark tetrad. And they're presenting a false pathology for secondary gain, oftentimes for financial gain. So that'd be the type of thing you'd see with maybe malingering or insurance fraud kind of things. So it's a manipulative exploitation of the systems by producing or by showing false pathology to the system. What we're having in the family courts is the factitious disorder imposed on another, classically called Munchausen by proxy. And classically, it's creating a medical or psychiatric pathology in the child for secondary gain, and it's associated with a borderline or histrionic spectrum parent, and the secondary gain is typically to get doctor attention and to be seen as the nurturing parent role. And so here we have the vulnerable dark triad is prominent in this display. For the family court, factitious disorder imposed on another, there's three potential secondary gain rewards that are provided to the pathological parent for producing pathology in the child. The first is court manipulation. So the pathological dark triad, vulnerable dark triad, dark tetrad parent is manipulating the court's decisions regarding child custody in their favor by creating the false pathology in the child. So that's gets the narcissistic spectrum, the dark triad and dark tetrad, because it's being rewarded. And so they're creating a false pathology in the child for the reward of manipulating the court, as well as the vulnerable dark triad that we'll talk about in a second. The second potential and prominent secondary gain for the allied parent in producing pathology in the child is spousal abuse of the targeted parent. And this is a prominent reward or secondary gain they receive, which is they are psychologically abusing the targeted parent using the child and the child's induced pathology as a spousal abuse weapon. And this pathology is primarily a spousal abuse pathology. And then by weaponizing the child, they create such significant pathology in the child, it becomes child psychological abuse as well. The third reward, reinforcer, secondary gain for producing false pathology in the child is the child is being used as a regulatory object for the pathological parent to meet that parent's own emotional and psychological needs. So the two variants, as I've mentioned before, there's a narcissistic variant and there's a borderline variant. The narcissistic variant is often in the pattern of a narcissistic father and a normal range mother. It has a higher spousal abuse feel to it, using the child as a weapon of revenge for the divorce. And here we're going to see the dark triad and the dark tetrad personality pathology. And then the borderline variant is often a borderline mother and a normal range father. And that has a higher anxiety and false allegations associated with this variant. And here we'll see the vulnerable dark triad parent. So to run down the secondary gain more specifically for the dark personalities and producing pathology in the child. For the narcissistic pattern, the dark triad and dark tetrad are highly manipulative. That's a symptom feature of the dark personalities, is Machiavellian manipulation. And so they are using the legal system, manipulating it as a weapon of spousal abuse, financial abuse, because it's very expensive to be in the courts, emotional abuse of the targeted parent by creating the pathology in the child. And when you have a normal range mother, that mother-child bond is very special. She bore the child. The child was part of her, and she tended the child during the early phases of development, 0 to 5. There's a very special mother-child bond there. And the father, the narcissistic dark triad, dark tetrad father, is destroying that bond as a weapon of emotional and psychological abuse. How dare you divorce me? You'll see, you'll be sorry. And then destroys the mother's bond to her children. And also in shaming the parent, the targeted parent, by going into the court and the court declarations. The narcissistic dark personality parent will shame the targeted parent. The narcissistic one shames by describing their inadequacy and how they're rejected, whereas the borderline spectrum tends to shame around disclosing sexual intimacies, those sorts of things. But it's a spousal abuse weapon in the family courts. And they're doing this in revenge for the failed marriage and divorce. And the theme you'll hear with that is the targeted parent deserves to be rejected. And that's your spousal abuse theme. Yeah, of course I hit her. She deserved it. My dinner was cold. She deserved it. The actual value system is we're not nice to other people because of who they are. We're nice because of who we are. But the narcissistic value system is the absence of empathy, and it's a capacity for cruelty. And so they go around and decide who deserves the cruelty for their inadequacy or failings. The borderline pattern is the vulnerable dark triad, and they manipulate the legal system by making false allegations of child abuse and domestic violence to obtain protective court orders that separate the child from the normal range targeted parent. And they describe the targeted parent as a dangerous person. So for the two variants, what you will tend to hear for the narcissistic variant, you will, when you explore why the child is rejecting the targeted parent, you'll hear the theme that the targeted parent deserves to be rejected because of their inadequacy. Whereas for the borderline variant, what you'll tend to hear is that the child is in danger from the targeted parent. And both of those are manipulating the court, but they're manipulating it in slightly different ways for slightly different emotional and psychological needs. So to understand, the legal system is the wrong system for a solution. A child rejecting a parent is a pathology that needs diagnosis and treatment. It's not a crime. So it's in the wrong system. The pathological parent is driving this into the legal system because they can manipulate the legal system, whereas the healthcare system will give a diagnosis and they don't want a diagnosis, and they'll treat it and they don't want treatment. They want the pathology because it's serving their own emotional and psychological needs. The healthcare system, diagnosis and treatment, is the proper system for the solution to family pathology. So the fact that we have this in the wrong system for a solution is indicative of the manipulation. That's a symptom feature of the dark, manipulation. And so the mere fact that one of the parents is driving pathology into the family courts rather than into treatment indicates that that parent is seeking to manipulate the systems. This is a pathology. Normal range parents will want treatment for the child's pathology, their attachment bond, or their fears, or whatever, and they'll move it into the healthcare system for treatment. The narcissistic borderline dark personalities will drive it into the legal system, make it about custody, possession of the child, because they can manipulate the legal system. And so when you have this symptom of the wrong system for treatment of pathology, then we're prominently consider the dark triad, vulnerable dark triad, and dark tetrad because the symptom feature is Machiavellian manipulation. So what we need to do here is, as soon as the pathology moves into the courts and the court sees a child rejecting a parent and there's a custody dispute around that, the court needs to move that family pathology out into the healthcare system as quickly as possible for a diagnostic assessment of the child's attachment pathology to the appropriate differential diagnoses for each parent. So the secondary gain of spousal abuse in the situation is that the dark triad and dark tetrad personalities are highly vengeful and retaliatory. And the divorce creates a narcissistic injury and narcissistic rage by it publicly exposing their inadequacy. Yet the only available access to the ex-spouse to enact the revenge is through their shared parenting of the child. So then they use the child as the weapon of revenge against the spousal partner, the ex-spouse. Oftentimes, for the narcissistic pattern, it's going to be the father who's using the child as a weapon of spousal abuse against the mother. And what we want to be especially concerned for this variant is sadism. Is there a gratification from causing the suffering in the mother? And that's the dark triad, and that's of high concern with this particular variant. For the borderline variant, the vulnerable dark triad collapses into a persecutory delusion. They collapse into their fears. So as opposed to having a narcissistic injury, the parent is collapsing into their anxiety and their unresolved trauma fears. And they present to mental health professionals in the court as a virtuous victim to enlist protective allies. And so they're trying to get people to protect them by signaling out anxiety and vulnerability. And they make false allegations of abuse, either of the child or domestic violence abuse, to again gain those protective allies. And they're seeking to increase their power through the allies, and by creating this false belief that the other parent, typically the father in this situation, is somehow dangerous to the child. And whenever there's an allegation of abuse or danger, that activates the mental health system, activates everybody to want to be protective of the child or protective of the spouse. And so they triangulate the child into the spousal conflict to gain power for the vulnerable dark triad relative to the other parent. Because if the vulnerable dark triad, the borderline mom situation, if she allows the father to have shared custody, she's very anxious about abandonment fears and got that splitting pathology. She's worried that the child's going to wind up having a good, positive relationship with his dad or with the targeted parent. And then the child will reject her because she's inadequate as a parent. She's borderline, and that's part of the feature of the pathology is the feelings of inadequacy. So, and she's got splitting, which is again a symptom feature. So she sees it as either or. The child either has to be on my side or on the other parent's side. And I can't allow the child to bond to the dad because then they're on his side and I'm going to be abandoned and rejected. So they keep the child close to gain power and manipulate the court's decisions so they're not abandoned. The secondary gain relative to using the child as a regulatory object is that the divorce represents, for the narcissistic parent, the divorce represents the exposure, public exposure of inadequacy for the dark triad and dark tetrad personalities, creating a narcissistic injury. And they seek to make the targeted parent then the inadequate and rejected parent person, and to restore themselves in the socially acknowledged role as the ideal, all wonderful parent person. So they're using the child to restore their narcissistic grandiosity and provide narcissistic supply from the general public of, yes, you're the ideal, wonderful parent, and then mom is the awful and inadequate mother, the bad mommy pattern. The borderline pattern is that the divorce triggers the abandonment fears for the vulnerable dark triad parent, who then uses the child as a regulatory object for the vulnerable dark triad's anxiety. And she seeks to prevent the child's bonding to the normal range parent to avoid those abandonment fears. So again, we're having the child being used as a regulatory object, but in slightly different ways based on the personality pathology of the pathological parent. So let's talk about the FDIA at this point, factitious disorder imposed on another, beginning with the false attachment pathology, which is the prominent false pathology being created. So we have three induced pathologies in the family court situation. First is we have the persecutory delusion, and that's going to be diagnosed separately. I have a separate seminar on diagnosing the shared persecutory delusion, but it's a shared delusion, so it's an induced delusion, so it's an induced pathology. The second is the factitious attachment pathology, and that's creating a false disorganized attachment towards the targeted parent for secondary gain to the allied parent for rewards. And then the third type of factitious disorder we will often see is the false phobic anxiety directed towards the targeted parent that's being induced in the child by the pathogenic parenting of the pathological narcissistic borderline dark allied parent. So the difference between the shared induced delusion and the factitious disorder imposed on the child, both of them are pathology being created in the child, and they're false pathologies. The difference between them is that a persecutory delusion is a thought disorder that's created by unresolved trauma that's distorting the person's current thinking and perceptions to where they see dangers where none exist. It's a problem in the thinking and perception systems of the brain, the frontal lobe executive function systems. Whereas factitious disorder imposed on another is a motivational pathology. It's of a parent who is inducing pathology in the child for the secondary gain, the rewards that are being provided to the allied parent for inducing pathology in the child. So it's a motivation to produce pathology in the child rather than a thought disorder that's distorting reality and their perceptions of reality. And so it's a problem. The factitious disorder is a problem in parental motivation that's the result of the rewards being provided to that parent for producing false pathology. And the rewards are manipulating the court, spousal abuse of the other parent, and serving as a regulatory object for their own emotional needs. So with the FDIA, factitious disorder imposed on another, relative to the attachment pathology that's being created, the child in the family courts is presenting with a disorganized attachment towards the targeted parent. The child is displaying no organized strategy to bond to the targeted parent. That's what a disorganized attachment strategy is, no organized strategy. And the cause, the research has identified, the cause for a disorganized attachment is either abusive or psychotic range parenting. So the first differential on having a child with no organized strategy to bond to the parent is differential diagnosis 1 would be, is the targeted parent abusive or psychotic with the child? When the answer comes back as no, then the second differential diagnosis becomes that the allied parent is the abusive, psychologically abusive, and psychotic persecutory delusion parent who's creating the child's induced disorganized attachment toward the other parent for secondary gain to the allied parent. So we're looking for a factitious disorder. Is it an authentic pathology, or is it a false, induced, factitious disorder being imposed on the child? But one way or the other, it's going to be child abuse, because that's the only thing that creates the child's symptoms in that situation of seeking to flee a parent. So here's from the ICD-11 diagnostic system. This is from the World Health Organization. So let me talk a little bit about the two diagnostic systems that are involved in professional psychology. First, in America, we have the DSM-5. That's from the American Psychiatric Association. That lists and describes all the psychiatric pathologies. And then the second diagnostic system is the ICD-11 from the World Health Organization, and that provides code numbers for all medical and psychiatric diagnoses. So for like billing purposes, when billing insurance, that we would use the ICD diagnostic system because it provides coding numbers for all the medical and psychiatric disorders. The DSM diagnostic system is just for psychiatric disorders, and they provide a more fulsome description of the pathology as well as research support for it and things. And so if you want a description of the pathology, it's typically more complete out of the DSM diagnostic system. This is from the World Health Organization, though. This is, quote, or these criteria for the factitious disorder are from the ICD-11, and the code number is 6D51, factitious disorder imposed on another. So the first criteria for factitious disorder imposed on another is characterized by feigning, falsifying, or inducing medical, psychological, or behavioral signs and symptoms of injury in another person, most commonly a dependent child associated with identified deception. Criteria 2 is that the individual then seeks treatment for the other person or otherwise presents him or her as ill, injured, or impaired based on the feigned, falsified, or induced signs, symptoms of injury. So when we apply those criteria to the pathology in the family courts, we have both of them are met. In the family courts, the allied parent induces psychological and behavioral symptoms in the dependent child to deceive the court and mental health professionals regarding the normal range parenting of the targeted parent. The allied parent then seeks treatment for the child and presents the child to the court and mental health professionals as being somehow injured by the normal range parenting of the targeted parent and as having an impaired attachment bond to the targeted parent based on the child's induced symptoms. So the diagnostic criteria for FDIA are met for the pathology in the family courts. And that's how diagnosis works. You compare the diagnostic criteria to the symptoms, and if there's a match, that's your diagnosis. If you match the 3 symptoms for schizophrenia, then you have schizophrenia. That's your diagnosis, whether you like it or not. It's the same way the legal system works. You have statutes with their criteria, and they apply it to the evidence. And if the evidence meets the criteria of the legal statutes, then you've committed that crime. Same thing in diagnosis. So the pathology meets the criteria for factitious disorder imposed on another. That is the diagnosis, if the criteria are met. So to explore how to make the diagnosis of factitious disorder imposed on another, it's basically a diagnosis by rule out. We have to rule out the authentic causes for the pathology. So if we Google factitious, the word factitious, you'll get the definition as artificially created or developed. So our diagnostic question is whether it's an authentic pathology or whether it's an artificially created pathology. So, so to make the diagnosis of FDIA, an authentic cause for the child's symptoms, which would in this case would be child abuse by the targeted parent, must first be ruled out as a cause, meaning that the symptoms are being artificially created. So we can't say it's artificial until we first rule out potential authentic causes for the symptoms. So here's our differential diagnosis relative to the pathology in the family courts versus one is authentic attachment pathology. The targeted parent is abusive somehow, child abuse, physical abuse, sexual abuse, neglect, or psychological abuse. That would create an authentic attachment pathology versus an artificially created pathology, which would be the allied parent is abusive, creating the shared persecutory delusion, the factitious attachment pathology imposed on the child, which would be child psychological abuse, and the spousal abuse of the targeted parent using the child as a weapon. So there's our differential diagnoses in this situation. Now, for a factitious disorder, we're going to put the factitious part on hold for a little bit. So that'll be pending. Our first, what we first have to do when we are worried about a factitious disorder is rule out possible authentic causes. So our first look will be at the targeted parent. Are they physically abusive, sexually abusive, neglectfully abusive, or psychologically abusive? And do we have an authentic attachment pathology relative to child abuse? And if that's not true, then we move over to the second diagnosis. So to assess true or false attachment pathology, what we will want to do is assess the direction of the motivation, the child's motivation. Are they seeking to bond to a parent and encountering problems, or are they seeking to flee a parent? Which direction is the motivation system motivating the child? So the first question becomes, does the child seek to bond to the targeted parent, but the bonding is being prevented by the exceedingly problematic parenting of the targeted parent? Now, normal range problematic parenting, or typically with problematic parenting in the targeted parent, it creates what's called an insecure attachment that more strongly motivates the child to bond to that parent. And it takes two different attachment styles. One is an anxious ambivalent attachment style. Of high protest, the child emits a lot of high protest behavior. And that's to elicit the involvement of an inconsistent parent. So that's important to understand. In normal attachment pathology, the anxious ambivalent, the high protest behavior, the conflict, is designed to acquire the involvement of the parent, not separate the child from the parent. And I'll explain why in a second. The anxious avoidant pattern of insecure attachment is where the child becomes low protest and becomes highly self-reliant. And that's to keep an overwhelmed parent close, because if the child protests, that parent goes further away. So by being low protest, and that's typically with a depressed parent or a substance abusing parent. So the child becomes self-reliant because that's the best strategy to keep the parent close. It's important when diagnosing and treating attachment pathology to understand the attachment system. That's where competence in attachment pathology is so incredibly important if you're diagnosing and treating attachment pathology. The attachment system is a motivational system, and all motivational systems for eating, pain, pleasure, sex, or attachment have a direction to them. They're not regulatory systems. Regulatory systems go up and down. Motivational systems motivate towards a direction. And the motivational system of attachment developed over millions of years of evolution because the other motivational direction is death by starvation and predation. So any child with a motivational direction to not bond to the parent died. And so, but any child who had the motivation to bond to the parent, that child survives. And that's the evolutionary origins of a primary motivational system for attachment bonding. So the attachment system always motivates the child to bond to the parent, because the other motivational direction is death by starvation and predation. So that's the important thing to understand in assessing attachment pathology. So start by assessing what direction is the motivational system motivating the child. So for the insecure attachments, it's called goal-corrected. The attachment system is a goal-corrected motivational system, meaning it always maintains the goal of forming an attachment bond to the parent. It changes how it tries to form that bond when it runs into a barrier. But the child is always motivated to bond to the parent because the other direction is death. And so we have the insecure ambivalent or the insecure avoidant when it runs into a barrier. Now, the other directional motivation is an aberrant motivation. And so that's caused by abusive parenting. So if the parent is abusive, the child will seek to flee the parent. So that would be an authentic attachment pathology caused by abusive range parenting by the targeted parent, who's creating an aberrant motivation in the child seeking to flee from that parent. The factitious attachment pathology is caused by psychological abuse by the allied parent, because there's no abuse from the targeted parent. The targeted parent is a normal range parent, so they are not causing that aberrant motivation. It's the pathological parent who is psychologically abusing the child and creating this aberrant factitious attachment motivation. So what we're going to look at is whether or not the targeted parent is abusive. And if they're not, if we can rule out the targeted parent being abusive, then we have a factitious attachment pathology because we have a directional change in the motivation. So it's a diagnosis by rule out. If you rule out the abusive parenting by the targeted parent, then we have the factitious disorder. So what we're looking at is that little box down there of normal range parenting. That's, if it's normal range, then we're looking at the factitious disorder versus if there's child abuse. And that's our primary initial focus of the assessment. So again, the normal range attachment motivation always motivates the child to bond to the parent because the other motivational direction is death by starvation and predation. So you have to understand what normal attachment bonding, what the normal attachment system looks like, what attachment pathology of insecure attachment looks like, and then we get the deviant motivation of a child seeking to flee a parent that's caused by abusive range parenting, and then we have to decide, is there abusive range parenting by the targeted parent, or is this a factitious attachment pathology? Once we rule out the targeted parent as being abusive, then we have the allied parent who's causing the pathology, this type of directional change in the attachment system. So we have the delusional disorder, the persecutory delusion. We have the factitious disorder imposed on the child. That would be child psychological abuse, creating a psychotic disorder that then destroys the child's attachment bond to the other parent, is psychological child abuse. And we have the spousal abuse of the targeted parent by the allied parent using the child as a weapon. So here's from Wikipedia on factitious disorder imposed on another. Just to get everybody just like on basics about what we're talking about here. From Wikipedia, the perpetrator with FDIA continues the abuse because maintaining the child in the role of the patient satisfies the abuser's unmet emotional needs. Generally, the cure for the victim is to be separated completely from the abuser and to receive the necessary emotional support from other loved ones and adequate treatment, such as therapy. Factitious disorder imposed on another, previously factitious disorder by proxy. The diagnosis is assigned to the perpetrator. The person affected may be assigned an abuse diagnosis, such as child abuse. So that's factitious disorder imposed on another. The pathological parent in the family courts is inducing the child's symptoms to meet their own emotional needs, the treatment is to protectively separate the child from the pathological parent. And over on the persecutory delusion seminar, the American Psychiatric Association twice indicates the treatment for a shared delusional disorder is to separate the child, which is why diagnosis is so incredibly important. Diagnosis guides treatment. The treatment for cancer is different than the treatment for diabetes. If we have a shared delusional disorder, the treatment is to protectively separate the child. If we have factitious disorder, the treatment is to protectively separate the child. That's the treatment for those diagnoses. Are those diagnoses present? Yes or no? We need answers to that question to guide our treatment for the child's attachment pathology. But we're not getting those diagnoses out of the current mental health people, which is extremely problematic. So I recommend, that's why I created the Parenting Practices Rating Scale. I created this scale where the involved mental health professional can, based on their clinical judgment and assessment of parenting, can document exactly where the targeted parent is. And the 4 pages or 3 pages, you just go through, checkbox, and you check what their type of parenting is, the quality of their parenting. Level 1 and level 2 parenting would be considered abusive range. That's clearly abusive or extremely problematic. Levels 3 and 4 would represent normal range. That would be normal range. There's some bumpy and some problematic, but it's normal range. And then we have level 4 is normal range healthy. I recommend that this be routinely collected in all families in the family courts, just to document what the parenting practices of the targeted parent are. Are they abusive or normal range? So everybody can get on the same page as to whether or not the targeted parent is abusing the child. Let's get a proper assessment of that. However, when parents go to their mental health people and ask them, would you please complete this? They are being told, no, I'm not going to complete symptom ratings for your child. And then they often retaliate against the parents, saying they're not cooperative with treatment or something because they've induced a narcissist. The level of professional practices in the family courts is phenomenally bad. Phenomenally bad. We just need to get this routinely collected, please. Because if it's a parent's normal range, if the targeted parent is normal range, they cannot be producing a child who seeks to flee from that parent. That's impossible. So that would be a factitious disorder. So can you please tell us whether the targeted parent is normal range or abusive, please, so we can get clarity on the diagnosis? Now, for assessing parenting, I have another in the diagnostic series that describes how to assess for parenting. And in that seminar, I talk basically, it's using an applied behavioral analysis out of behavioral psychology. You take incidents of parent-child conflict, you start with them before the event, during the event, and after the event, and you look at thinking, feeling, and doing. Thinking, feeling, and action. And you do what's called a behavior chain interview. That involves stimulus and response, B.F. Skinner's, stimulus produces a response, and you start going through the conflict. So what did you say? What did the child respond? Okay, then what were you thinking and feeling? What did you do in response? And then what did you do in response to what the child did? And then what did you do in response to parent? And we simply walk through a sequence of what took place, looking at the stimulus response pattern, the sequences, and that identifies the cue that's triggering the behavior. So that's how you assess for parenting. Another approach you can do to assess for true authentic pathology or factitious pathology is called a response to intervention. And that involves identifying the stimulus control for the child's behavior. What stimulus is inducing or controlling the child's symptoms? And typically, in explaining this to students, we use a traffic light as an example. When the stimulus is red, we stop. When the stimulus is green, we go, and yellow is a transitional warning. and behavior is in response to the cue. It's a stimulus response thing. Our driving behavior is in response to the cue of the traffic light. So a response to intervention changes the parent's behavior, so changes the traffic light, the cue, the stimulus, and we should see a corresponding change in the behavior, the response, if it's authentic. If the child's behavior does not change in response to the changed cue, in response to the changed stimulus, then the child's behavior is not being triggered by the parent. It's not under the stimulus control of the parent. It's getting triggered by the allied parent. And so it's like if you were sitting at a traffic light, if you're watching somebody sit at a traffic light and the light's red and they're waiting, the light goes green and they continue to sit at the traffic light, their behavior, their driving, is not under the control of the traffic light. You can change the traffic light to any color you want. It's not going to change because they're not under the stimulus control. So if the child's behavior is not under the stimulus control of the targeted behavior and what they do, you can change that parent's behavior till forever, and it won't affect the child because there's no stimulus response connection there. The stimulus, the cue, is coming from the allied parent, and loyalty conflicts and the manipulation, psychological control issues. So that's another way to tell the authentic versus inauthentic parenting. So now here is for authentic conflict. This is what authentic conflict would look like. We have in the upper left there, you'll see the child is encountering some sort of barrier to bonding. But you see the child's motivation is to bond to the parent. So we have a proper motivational direction, but it's encountering some sort of problematic parenting, a barrier. So that's producing the high protest behavior, the conflict of the insecure, ambivalent type of attachment. So we get that high conflict there. The response to intervention is to remove the barrier and allow the motivation to achieve its goal of forming an attachment bond to the parent. That would be a normal attachment system, a normal conflict. That is the treatment for attachment pathology. Okay, let me clarify that really well. The treatment, I'm early childhood mental health. I knew 2 different attachment treatments out of early childhood: Wait, Watch, and Wonder, Circle of Security. I know the attachment system. The treatment for attachment pathology is the child wants to bond to the parent. There's some sort of barrier. You identify what the barrier to bonding is, you remove it, and boom, the child bonds into the parent. It's an easy fix with a cooperative parent. If you don't have a cooperative parent, you have a substance abusing parent or something, then we have the barrier. We can't get rid of the barrier. But if we got a cooperative parent, we just get rid of the barrier and boom, the child pops back in. So for the family courts with a targeted parent who wants to be cooperative and then says, I want my child, I want to love my child, I would put treatment at 2 to 6 weeks for a full resolution. Just remove whatever barriers there and boom, you fix things. However, that's not the problem. Okay, we have the third one down there, which is an inauthentic conflict. And there's your response to intervention. You remove the barrier, but the child isn't wanting to bond to the parent. The child wants to flee the parent. But there's no abuse making the child want to flee. That's not an authentic conflict, the one at the bottom. And so there's a variety of ways to identify whether it's an accurate or true pathology or not. But you must be competent in the diagnosis of attachment pathology if you're diagnosing attachment pathology. And the problem in the family courts right now is that none of the mental health professionals working in the family courts are competent in attachment pathology. They're not competent in delusional thought disorders. They're not competent in family systems. They're not competent in a lot of things, but delusional thought disorders and attachment pathology, when the pathology is a delusional thought disorder and attachment, that's just creates nightmares. That creates the current situation where you get misdiagnosis and mistreatment. And if you believe a shared delusion, you become part of the shared delusion. So we have mental health professionals out there who are participating in the child abuse and spousal abuse because they're practicing beyond the boundaries of their competence and they don't know what to do. So the other type of factitious pathology that we find in the family courts is a factitious phobia. And this is not always. Typically, it's for the younger children, 4 to 6, 7 years old. Typically on the borderline vulnerable dark triad variant is you will get this factitious phobia. And what that is these are the DSM-5 criteria for specific phobia, but it's a false phobia of a mother type or a father type that doesn't exist. So here would be the symptom features for a false phobia being created in the child. Does the child display a persistent and unwarranted fear of the targeted parent that is cued either by the presence of the parent or in anticipation of being in the presence of the parent? And then you have a severe anxiety response, which is, does the presence of the targeted parent almost invariably provoke an anxiety response in the child, which can reach the level of a situationally provoked panic attack? The third criteria is the avoidance of the parent. Does the child seek to avoid exposure to the parent due to situationally provoked anxiety, or else endures the presence of the parent with great distress? So I see this all the time. Okay, I see this anxiety presentation where the child is saying, a tremendous fear of the targeted parent being provoked either by being with them or even anticipating them. They'll produce a child, and we're getting reports from the allied parent. They're saying the child is too scared, and I tell them they're going on visitation. The child becomes very upset, even to the level of panic attacks. The child's having panic attacks about being with the targeted parent, and they seek to avoid that parent. Check, check, check. If the child meets the diagnostic criteria, then that's the diagnosis. That's how diagnosis works. And so we have a false phobia being induced in the child. Now, the reason is because that's the layperson in the allied parent and child. That's their belief as to what PTSD would look like. If there's been a trauma, then the child's going to show all these fears. That's not the PTSD diagnosis. But they're trying to mimic a PTSD situation, and they wind up creating a specific phobia. And so you got to know what you're doing. If you're a doctor, you got to know factitious disorders, and factitious disorders imposed on a child, personality disorder pathology. The doctors must be competent in the pathology, or otherwise you're going to get misdiagnosis and mistreatment. When it's child abuse, that can have severely devastating consequences for the child. So, the factitious phobia imposed on a child. There are a lot of phobias. There's papaphobia, which is the fear of a pope. There's megalophobia, which is a fear of large things. There's insectophobia, the fear of insects. Cyclophobia, the fear of bicycles. Barophobia, the fear of gravity. There's phobias about a lot of things. However, there is no such phobia as a mother phobia or father phobia. The attachment system prevents that from developing. That's a non-existent phobia. That's a false, factitious anxiety disorder being imposed on the child by the pathogenic parenting of the allied parent. Let me take a second to talk about anxiety and behavior, as long as we're talking about false anxiety disorders. Even in the narcissistic variant, you'll get the child saying, I'm anxious about being with the other parent, but then when they're with the parent, they're very aggressive, hostile, and demanding, haughty and arrogant attitude and things. Anxiety, fear, induces submissive behavior. I've worked child abuse. I worked foster care. A child does not challenge the authority of an authentically abusive parent because that parent is a dangerous human. Fear produces submission, not angry. If a child is challenging the authority of a parent, that child is not afraid of that parent's response. So anger is a dominant emotion. Fear is a submissive emotion. So if I have a child displaying anger towards the targeted parent, a haughty and arrogant attitude, judging that parent, saying, I'm not going to be with that parent, defying that parent, that's a dominant emotion. Now, if I have the child verbally saying they're anxious and afraid of that parent, that's just entirely an inconsistent symptom. That's a factitious attachment symptom. Now, it won't meet criteria maybe for the specific phobias you get in the borderline vulnerable dog triad, but you still have this factitious anxiety up there because they're trying to mimic the PTSD diagnosis. And let me say, on any of the individual therapists or even family therapists who are misdiagnosing PTSD in the child, you're being manipulated because of your incompetence. Criteria A of a PTSD diagnosis is exposure to death, serious injury, or sexual violence. That's the first criteria of PTSD. Has the child in the family courts been exposed to death, serious injury, sexual violence? No, it's not PTSD. It's a false PTSD. It's a factitious PTSD. They're trying to manipulate you by presenting symptoms, but you are so incompetent, you don't even read the DSM-5 for PTSD before you give the diagnosis of PTSD. And you become part of the pathology because you believe the shared delusion. You believe the false pathology. And so you become a participant in creating the child abuse in the child by believing that there's child abuse and by not protecting the child. The level of incompetence is phenomenal and needs to be corrected. If we treat cancer with insulin, the patient will die from the misdiagnosed cancer, and that's what's happening. So here's the diagnostic questions that need to be answered. First, that the targeted parent abusive? Yes or no? Is the targeted parent abusing the child in some way? If yes, specify the type of abuse. We're going to put it on a treatment plan. We're going to fix it, and the child's going to bond back into that parent. Okay, so is the targeted parent being abusive? Or is the allied parent being abusive? Yes or no? We need a yes-no answer to that. Is the allied parent psychologically abusing the child by creating a shared persecutory delusion in the child? You can look at my other seminar on diagnosing a shared delusion to answer that question. Yes or no on the third one. The allied parent is abusive. Is the allied parent psychologically abusing the child by creating a false, factitious attachment pathology in the child for secondary gain to the parent? We need a yes-no answer on that. Okay. And then the fourth diagnosis that's involved is the allied parent using the child as a weapon of psychological spousal abuse of the targeted parent? Now take a look at each one of those diagnostic questions that need to be answered. Abusing, 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 abuse. So the differential diagnosis that we need answered has to do with child abuse. So that means the duty to protect obligations for all mental health professionals are active, and we need to get a proper risk assessment for child abuse. This is not a custody issue. That's being manipulated. It's driving it into the court and making it seem about custody. It's not. It's a pathology issue and it's a child abuse issue. We need to get a proper assessment for child abuse, please. Okay. All mental health professionals have a duty to protect. In all cases of court-involved custody conflict involving severe attachment pathology displayed by a child rejecting a parent, a proper risk assessment for child abuse needs to be conducted to the appropriate differential diagnoses for each parent. All cases. And so with that, that's the seminar on how to diagnose factitious disorders imposed on another. I'll be going on to talk about the diagnosis of attachment pathology, the personality pathology, the family systems pathology, treatment-related issues. And we are already present are seminars on the DSM-5 diagnosis, delusional thought disorders, assessing parenting, and problematic practices in forensic psychology. So with that, I'm going to wrap up this seminar and head off to the rest of my day. Good luck, everybody.